Most people expect some discomfort during a period, but for many women, period pain isn't a mild inconvenience. It's days of severe cramps, nausea, diarrhea, back and leg pain, exhaustion, missed work or school, and the feeling that life has to pause every month. That kind of pain is often minimized. You may have been told to take a paracetamol or that it will improve after having children, but severe period pain has a medical name, dysmenorrhea. In this video, we'll break down dysmenorrhea clearly, what it is, the difference between primary and secondary dysmenorrhea, common causes, red flags that need assessment, what you can try safely, what treatments are commonly used in the UK, and what to ask your GP so you leave with a plan. This is not about labeling every period cramp as a disease. It's about recognizing when pain is a symptom that deserves proper care. Dysmenorrhea simply means painful periods. It usually describes cramping pain in the lower abdomen during menstruation, but it can also include back pain, pain down the legs, headaches, and digestive symptoms. There are two main types. Primary dysmenorrhea. This is a period pain not caused by another medical condition. It's usually linked to prostaglandins, chemical messengers that make the womb contract to shed its lining. Higher prostaglandins can mean stronger contractions, reduced blood flow, and more pain. Secondary dysmenorrhea is a period pain caused by an underlying condition, such as endometriosis, adenomyosis, fibroids, pelvic inflammatory disease, or issues related to contraception. For example, some people have pain with a copper coil. This distinction matters because primary dysmenorrhea often responds well to certain treatments, while secondary dysmenorrhea requires investigation and targeted management. A helpful way to think about normal is not the presence of pain, but the impact. Mild to moderate cramps that respond to standard pain relief and do not disrupt your life may be common, but period pain should not routinely make you miss work, school, or caring responsibilities, make you vomit or faint, wake you from sleep, require you to take maximum painkillers for days with little relief, be getting worse over time, be associated with heavy bleeding, bleeding between periods, or pain during sex. If the pain is stealing your life, it deserves attention. When you speak to your GP about severe period pain, they'll usually begin by taking a detailed symptom history. When the pain happens, how severe it is, and how it affects your daily life. Then ask about your bleeding pattern and contraception. Check whether pregnancy is a possibility if relevant, and ask about any signs of infection, such as discharge changes or fever. Depending on your symptoms and with your consent, they may also do a pelvic examination and arrange tests such as a pregnancy test, STI tests if indicated, and blood tests to check for anemia if heavy bleeding is a concern. If your GP suspects a secondary cause for your period pain, they may arrange imaging such as a pelvic ultrasound and refer you to gynecology for further assessment. And a practical way to support that process is to track your symptoms for a few cycles. Note when the pain starts, for example, days before your period or only on day 1. Rate it on a 0 to 10 scale, record how many doses of pain relief you need and how well they work, and document the real-life impact, such as missing work or school, being bedbound, or feeling nauseous or vomiting. This makes it easier for clinicians to see severity and pattern. There are supportive measures that can help many women, especially with primary dysmenorrhea. Anti-inflammatory painkillers such as ibuprofen can be effective because they reduce prostaglandins, and they often work best when taken early, following advice from your pharmacist or clinician, alongside simple strategies like using heat with a hot water bottle or heat patch, doing gentle movement if you can tolerate it. Some women find walking or stretching eases cramps, planning extra rest and sleep on the worst day or two, and keeping up with hydration and regular meals, particularly if nausea is an issue. And before taking any anti-inflammatories, such as ibuprofen or naproxen, it's important to check what is safe for you personally, especially if you have asthma, a history of stomach ulcers, kidney disease, take blood thinners, or have any other medical conditions where these medicines may not be suitable. If pain is recurring and affecting your life, it's reasonable to discuss medical treatment rather than suffering monthly. Common options include hormonal contraception, combined pill, patch or ring to reduce ovulation and often reduce pain. Progestogen options, mini pill, injection, implant for some women. Levonorgestrel releasing intrauterine system, IUS, which can reduce bleeding and pain for many. If secondary causes are suspected, treatment may focus on the underlying condition, for example, endometriosis management. What you deserve is choice. Some women want symptom control now, others want fertility preserved. The plan should reflect your goals. While dysmenorrhea itself is common, the following symptoms should be checked urgently. Severe sudden pelvic pain unlike your usual cramps. Fainting, collapse or severe weakness. Fever with pelvic pain. Vomiting that prevents keeping fluids down. Heavy bleeding where you feel dizzy or lightheaded. Possible pregnancy with pain and bleeding signals ectopic pregnancy risk. You know your baseline. If something feels dramatically different, trust that. Monthly pain can erode your mental health. It can affect intimacy, work performance, exercise, and confidence. Many women also feel guilt, like they're not coping. You are not weak. Recurrent pain is draining. If you've been dismissed, that can be as traumatic as the pain itself. Support can include asking your GP to document severity and impact, seeking gynecology assessment if symptoms persist, finding community support while still relying on evidence-based guidance. Considering mental health support if anxiety, low mood, or trauma responses develop around your cycle. If you want your appointment to move beyond take painkillers, you can ask, can we talk about dysmenorrhea and whether mine might be primary or secondary? Because this pain affects my life, can we investigate underlying causes like endometriosis or adenomyosis? Can we arrange a pelvic ultrasound if appropriate? What treatment options can reduce pain and bleeding, and what are the pros and cons? If we try treatment and it doesn't work, what's the next step and timeline? Can we check iron levels if my bleeding is heavy and I'm exhausted? What symptoms would mean I should seek urgent help? You are not asking for too much. You're asking for healthcare. And if part of you worries that asking questions or requesting checks is overstepping, I want you to pause there, because not advocating for your health can sometimes cost people years of pain, delayed diagnosis, and serious complications. Health professionals work under real pressure, and appointments are short. That doesn't mean they don't care. It means details can be missed and patterns can be harder to spot in a 10-minute slot. So your symptom diary, your questions, and your prompts are not an inconvenience. They can be the missing piece that leads to the right investigation and the right plan. I've added a few public stories and resources in the description, real experiences from women who kept pushing for answers, so you can read them and feel less alone, and so you can walk into your appointment feeling more confident. Dysmenorrhea is real. It has mechanisms, causes, and treatments, and whether your pain is primary or secondary, you deserve a plan that reduces suffering and protects your long-term health. If your period pain is affecting your life, take that seriously. You deserve relief, clarity, and to be believed. If your period pain comes with heavy bleeding, clots, pelvic pressure, or a deep aching pain, it may be helpful to learn about adenomyosis because it's one of the common causes of secondary dysmenorrhea and it's often missed. Tap the thumbnail on your screen now to watch our adenomyosis video so you can recognize the patterns, understand diagnosis in the UK, and know what to ask your GP next.